My name is Angel Zamora, and for my presentation, I will be discussing particulate matter pollution in Europe, health hazards, and imperatives for action. While researching this rising global issue, I found that there are specific compounds that are gaining notoriety. These compounds are known as PM2.5. PM2.5 comes from various sources, from coal power plants to wildfires to volcanic activity and vehicle emissions. However, PM2.5 from coal power plants is much more significant, so this source has become the primary focus for researchers and public health advocates. PM2.5 refers to particulate matter that is 2.5 microns or micrometers in diameter. They typically are the result of reacting gases in the atmosphere such as nitrogen oxides or sulfur oxides. They are also commonly emitted in power plants, manufacturing facilities, and large-scale combustion processes. Still note, however, that there are smaller ambient sources such as vehicles, heating, and wood-burning stoves or fireplaces. While researching, it was a little hard to comprehend how big PM2.5 was as a structure, but I was able to find this image here that very effectively depicts the size compared to something as universal as a grain of sand and a strand of hair. As you can see, the average grain of sand is typically 90 microns in diameter, and the human hair is typically 50 to 70 microns in diameter, depending on thickness. Scaling down, we can see a reference point of PM10, which is 10 microns in diameter. This is approximately the size of dust particles and mold. Going further, inside of the PM10 illustration, you begin to really understand the size of PM2.5, as you would be able to fit 4 PM2.5 particles across the diameter of one PM10 particle. An interesting little side note here is that we are unable to see compounds below 40 microns, so this is of course invisible to the naked eye. So why is PM2.5 so concerning? Well, now that you understand the size, you can understand that because this particle is very small, it has a very strong ability to penetrate into the respiratory tract and make its way into the bloodstream. This is concerning because PM2.5 is found in densely populated industrial regions and urban areas throughout Europe, where there's a lot of sources for emission. People living in these high exposure environments become even more at risk when they fall into a subcategory of vulnerable populations. This includes children, elderly, and individuals with pre-existing health conditions, which become even more amplified if they were respiratory conditions. When a population is exposed to high amounts of air pollutants, health implications of PM2.5 exposure include a range of acute and chronic symptoms, exacerbating asthma, respiratory infections, and contributing to chronic conditions such as chronic obstructive pulmonary disease, heart disease, lung cancer, and even premature death. With that background, I can now go into the findings of my primary EHP article when researching this subject. My primary research article was made to assess the health impacts of CPPs, or coal processing plants, in Europe, with the focus on the excess mortality associated with exposure to PM2.5. This was done by utilizing the Global Exposure Mortality Model, or GEMM, to determine hazard against comprehensively recorded PM2.5 levels. This article found that in excess of over 18,000 to over 105,000 deaths annually are a result of emissions such as PM2.5, a number that could be reduced with significant change towards a phase-out in CPPs. While researching reasons for such a high death rate as a result of PM2.5 exposure, I was able to find a load of supporting articles that each focus on subsections to what may specifically have caused mortality, such as diseases linked to PM2.5. Many of these studies aim to determine who was at risk of population exposure, as well as applying well-known data towards models to understand just how deadly of a health risk this is. This article does just that by using data collected from 41 cohorts across 16 European countries. The findings from this article indicated that PM2.5 contributes to more deaths than is currently globally recognized, highlighting PM2.5 as a major health risk comparable to risks such as tobacco use. This also established a similar high-risk population as a primary EHP article, such as elderly, young, and those with respiratory complication history. It also established bigger populations such as urban areas, industrial areas, and generally high-traffic areas at being higher risk. An article that I also found focused on more direct impacts of PM 2.5 exposure against cardiovascular diseases in European populations. This article found that ambient air pollution in Europe was linked to have an effect on as much as 80% of deaths attributed to cardiovascular events. This expands the risk of PM 2.5 exposure as well as providing mechanisms in which inflammation, oxidative stress, and vascular dysfunction occur to broaden an understanding of PM 2.5. Comparing the findings of this to discussed articles, you can see that they reaffirm populations, especially when discussing individuals with previous health complications. A more recent and more applicable study I found was one focused on COVID-19 mortality rates that were linked to air pollution exposure. The data provided in this study further supports the correlation between PM 2.5 and the severity of diseases, possibly exacerbating viral infections such as COVID-19, by compromising respiratory health and function due to increased airway permeability. When quantifying these results, they were able to find an almost linear increase in mortality with rising PM 2.5 levels. They estimated that a 10.5 increase in mortality was associated with 1 micron per cubic meter of PM 2.5. This of course indicates that higher PM 2.5 levels are in fact associated with the higher COVID mortality rate. These findings of course overlap as they contribute to a persuasive trend of regions of high pollution peaks such as areas by coal power plants being most at risk of both chronic health conditions and acute infectious diseases. When looking at a more broadened study, I was able to find a source that used a generalized least square model to associate PM 2.5 to lung cancer risk and increased mortality rates from cardiovascular diseases, supporting and expanding on the previously discussed articles. One interesting factor before getting into the results was that they noted a trend of increased income being associated with a lower PM 2.5 exposure and thus a decrease in mortality rates. Their results did, however, link chronic exposure of PM 2.5 to being able to cause chronic obstructive pulmonary disease, as well as acute lower respiratory infections. They also listed a clear link between prolonged exposure to increased risk of lung cancer, as well as mortality from cardiovascular diseases such as a stroke or ischemic heart disease. When looking at the collective data between these studies, you can see they highlight the importance of PM 2.5 pollution on public health throughout Europe. Multiple findings throughout the study clearly show that there is a common trend of PM 2.5 exposure and adverse health effects, from cardiovascular, cancer risks, and even death. These are again heightened when living by high traffic areas or industrialized zones, and even in urban centers. In an applicable sense, the results of these studies show that there is a great need for much better air quality regulations provided in Europe, especially near large ambient emitters such as coal power plants. All studies provide strong evidence to guide policymaking decisions to safeguard public health and promote environmental sustainability throughout Europe. Thank you so much for listening to my presentation on the impact of PM 2.5 exposure in Europe, and here's a reference page to leave off on if you want to take a look at the studies.